Another dilemma is double vision. When a patient comes with double vision, I hand over to Dr. Meena CK. She is a pediatric ophthalmologist in Little Flower Eye Hospital, Cochin.
Very good morning to all. At the outset, I would like to thank Laila Madam and AIOC2024 for this opportunity. I'll be speaking on investigating a patient with double vision. As all of us... Okay, double vision or diplopia, it's usually due to misalignment of the eyes with an absence of the fusion of images at the cortical level and each eye perceiving images separately. So always it need not be due to misalignment. So it can be due to neurogenic causes, and it can start from the nerves, the neuromuscular junction, or the muscle itself can cause, and also local ophthalmic causes. So how to approach a patient with double vision? So whenever a patient comes to you with double vision, you have to get a detailed history, and then itself you can come to a more or less come to a diagnosis. Not the correct diagnosis, but at least it will lead you to a diagnosis. So first you have to see if it is monocular or binocular, if it is of acute onset, which can be dangerous, and if it's long standing, that is if it is intermittent. Then you have to find out what type of double vision it is. It's whether it is horizontal, vertical, oblique, and mode of onset, like if there was any trauma, any iatrogenic causes, like if they had any surgeries, example is sinus surgery, and diurnal variation, which involves more of muscle involvement or neuromuscular junction involvement and associated features. Now coming to the monocular part, always you have to occlude either eye and see whether it's monocular. Most of the monocular double visions are due to local causes. So you need a proper examination of the eye to make sure that it's not monocular. So monocular common causes could be even with severe dry eyes. You can get keratoconus, subluxation, and also take a pinhole vision and a proper slit lamp examination. So first rule out whether it's monocular or binocular. Now coming to the binocular one, which is we are more concerned about, and also which needs a proper diagnosis, you can think of a committant part and an incomittant part. That is, incomittant, when in an ophthalmologist point of view, you track towards a third, fourth or sixth cranial nerve. It's not that you have to not think about the other cranial nerves, but your main concern will be the third, fourth or sixth cranial nerves, or a combination of them. And coming to the committant part or the non-paralytic, that what I mean is that you have normal extraocular movements. Then you should think of conditions like uncorrected refractive error, especially in the presbyopic age. People who resist using glasses, they can come to you with complaints of double vision. So always rule out that. And also the acute acquired committant esotropias, which has become so rampant in the COVID times because of increased screen time. So you have to rule out that, and decompensated strabismus also, especially intermittent exotropias, where they can come with double vision even at an older age. Now in any forms, you have to go for a routine ophthalmic examination, which will include with a head posture, which start with an head posture and ocular posture, and you should think of turns which usually occurs in horizontal problems, and tilts and chin elevations and depressions, which usually are due to the vertical muscle problems, and also the associated features of the eye, like as you have in ptosis. So this child you can have the typical head posture of head tilt and a chin depression. She had a trauma with an injury to the inferior recti muscle, and she could read only in this particular position because of the double vision. Now the routine examination of the eye, where you have to give a little emphasis for the orthoptic evaluation, and also the pupil needs special attention in cases of double vision. Now coming to the extraocular movements, the assessment of extraocular movements in single nerve palsies, it is usually you can come to a diagnosis with the assessment of the extraocular movements. So the versions are important, and you can assess the versions first, because in conditions like gaze palsies, where ductions and versions can be different, so versions help in assessing the gaze palsies, and also you can compare both the eyes in versions. And ductions are usually uniocular movements, and vergences, where the eyes are moving in different directions. So versions, the help of the version, the main importance of versions is that you can compare both eyes. Like if you have a subtle overaction, you may not make out if you do it in a adduction, and also you have to assess it in all the 9 cardinal positions. Especially here you can see that's a very small inferior oblique overaction which you may miss if you don't examine both eyes together. Now ductions, obviously they are uniocular movements, and significant changes like this or very obvious changes where you can see that there is a very significant limitation of the abduction, which is obviously due to an abducent palsy. So such things you can get an immediate diagnosis with just assessing the duction. And third nerves usually adduction, elevation and depression, and fourth nerves torsions. And vergences, the convergence insufficiency and convergence problems is yet another cause which I missed in the earlier committant part, are problems that can cause double vision. So you have to assess your convergence extent and limits and divergence limits. And whenever you do an extraocular movements, you try to document them. So that is very important, because when you go back into the chart, you know that how much of limitation the patient had, and when they come for follow-up, you can compare it. Like here you can see that the eye is not even coming to the center. So you can say that when it's in the center, you call it as -4 limitation, and if it's beyond that, you can grade your limitation. So this patient, the eye is not even coming to the center. It's almost like a -5 limitation of abduction in the right eye, which was a 6th nerve palsy. And here you can see a significant overaction of the inferior oblique, that is in and up. So here you can document. So documentation of extraocular movements is important. Now, this is one form of palsy that is difficult to assess, like superior oblique palsy. The patient might come to you with the typical symptoms like walking down steps is difficult, and suddenly they have developed a double vision, and the deviation is usually subtle in such cases, in most of the cases. So the head tilt test is a very important test in especially in hyperdeviations. Like here you can see that on head tilt to the left side, there is a significant hyperdeviation. So this head tilt test has to be done whenever you see that it's ideal. It is better to do in all cases of especially in very small forms of hypertropia. So head tilt test, it must, and also you have to measure it when you get an idea as to which muscle is overacting or underacting. Now, before you go on to covering any eye or either eye, you should do a proper sensory evaluation. This is mainly for malingers. So many children come to you with complaints, parents complaining that the child is seeing double, triple and all. So better to do a sensory evaluation before you do a cover test or anything, because if they have a very good stereopsis, it's unlikely that they are having diplopia. So otherwise also any orthoptic evaluation, it's better to do a sensory evaluation first before you go on to a motor evaluation. And you have to assess all the 3 grades of binocularity before you go on to measuring the deviation, if any. So now when you feel that the deviation, you have a doubt, like diplopia charting is a very good tool. Diplopia charting you need not do in all cases. Like if you're sure of your diagnosis, then it's fine, but still for documentation it is extremely useful. This is not the ideal condition how you do, like ideally you have to do it in a dim lit, dim illumination. I'm just showing it to show the demonstration by the patient. So the patient should demonstrate how they see the images. So it is shown that torch with a slit and a red-green goggles for the patient. It is shown in all the 9 cardinal position, and the patient has to patient himself demonstrate how he sees the images. So what are the conclusions that you get from a diplopia charting is that whether the images are crossed or uncrossed. That itself gives you lots of information. And usually it is red in front of the right eye and green in front of the left eye. That too you have to document. And how the images are separated, whether it's a horizontal separation or whether it's a vertical, oblique or a combination. And also the things that you can get from a double vision, the informations are where the maximum separation of images is occurring, in which box. And then you should think of the yoke muscle in that particular direction. So you should have an idea of which are the muscles which are acting in those particular direction. So when you just look at the box which has maximum deviation, and then you know that mainly it is the two muscles, and from that you have to find out which muscle and the corresponding nerve. And always the outermost image will belong to the affected eye, and horizontal uncrossed images, usually the lateral rectus is involved, and crossed it is medial rectus. And these are the few tips, like in vertical diplopia, when you have uncrossed, usually the obliques crossed vertical, and tilt to the sound side in superior when superiors are involved, and tilt to affected side the inferior. And the HES charts and rescreen we are not using nowadays much, but they are helpful for documentation. And systemic evaluation is extremely important. Like if you have a diabetes, hypertension, etc., you have to rule out all this, and lid changes, thyroid association which can cause committant strabismus, committant double visions, myasthenias, inflammations, and other cranial nerve examination. And the red signals for neuroimaging are younger age of presentation, multiple cranial nerve involvement, recurrent cranial nerve neuropathy, evidence of increased intracranial pressure, and aberrant regeneration if no imaging was done earlier, and no improvement in 6 weeks in double vision when they are associated with a systemic condition and trauma. So double vision assessment prerequisite: patient and examiner should be patient, and proper understanding of extraocular muscle functions and nerve supply, documentation and neuroimaging when and where needed. Thank you.
Thank you, Dr. Meena, for that exhaustive diagnostic techniques for a patient who comes with double vision.